Hello, let's discuss the next station from the critical care, and that is atrial fibrillation. Okay, and ruptured viscus. So the scenario is elderly gentleman has abdominal pain, looks confused, chest X-ray and ECG inside the cubicle. So let's answer the question. You are shown a chest X-ray and ECG. So this is the X-ray and this is ECG. Okay, how to read chest X-ray and is it adequate or not? So in order to read the X-ray, we have to tell about the demographics like patient name, date of birth, age of the patient and gender of the patient. Then we have to ask for previous films. Okay, and then radiograph detail, date of the radiograph. Okay, the view, is it AP or PA view, or is it inspiration or expiration or standing or supine. Then we will check for adequacy, is it adequate or not. So for adequacy, remember the ripe. Okay, remember the ripe. R for rotation. Rotation means the medial borders of the clavicles are equidistant from the spinous processes. Okay, then I for inspiration, at least 5 to 6 interior ribs will be visible above diaphragm if it is inspiration. Then the picture area, does the radiograph have lung apices, diaphragmatic recess, scapula out of the way. Then we have to look for exposure of the vertebral bodies. Okay, so it will be adequate. Then we interpret, we will comment on the airway, the tracheal deviation. Okay, if there is any tracheal deviation, then it may indicate pneumothorax or large effusions or rotation. Then breathing, for breathing, we have to look at the lung fields to look for air, fluid consolidation, lobar collapse or any lesion. Then circulation, in the circulation we have to comment on heart size, heart position, heart shape. Great vessels like the aortic knuckle should be visible, mediastinal width. Okay, then we have to look for diaphragm, the costophrenic angles, air below the diaphragm, and the extra things like bones and soft tissues. Okay, so this is how we will read the X-rays. Okay, so so this is how we will read the X-ray and how we will check the adequacy. Then you can see this ECG. Okay, this ECG, first you have to look at rhythm, whether it is regular or irregular. So you can see, you will check the rhythm by looking into RR intervals. So you can see the RR intervals are irregular, which mean this X-ray is irregular. Okay, irregular rhythm. While then you have to check that whether this is sinus rhythm or not sinus rhythm. So in the sinus rhythm, there will be P wave followed by QRS complex and then T wave. So you can see there is no T wave in the this ECG. Okay, these ECGs have no P wave. Okay, and the irregular pulse or irregular rhythm. So the absent P waves and irregular pulse shows us the that this ECG shows the atrial fibrillation. Okay, while if we look at the X-ray, so the pathology in the X-ray, is that there is air below the right diaphragm. Okay, the air under diaphragm. This air under below the left diaphragm is of the stomach shadow. Okay, but air below the right diaphragm is due to perforated bowel. Okay, So identify the pathology in the ECG. We have already located that there is absent P wave, and the rhythm is irregular. So it is atrial fibrillation. Why? Because irregular rhythm and no P waves. Then this is the question, how to read the ECG. So there are two steps in interpretation process. First step is descriptive analysis, then the step 2 is formation of the clinical impression. Okay, so the 6 parameters in descriptive analysis to assess are: the first will be rate, then the rhythm, then intervals like PR, KORS and KOT interval, then axis deviations, left or right axis deviation, hypertrophy and ischemia. In the ischemia, we have to look for any KORS RT changes. Okay, so this is how we will read the ECG. Then count the heart rate in ECG. Okay, so in this, okay, so as we already in the previous lecture we have we have told that the if the heart rate is regular, okay, if the heart rate is regular, then we will divide the 300 divided by number of large square, okay, large squares or large block in between RR interval. But as this X-ray is irregular, then we have to count the number of KORS in the 30 blocks or 6 seconds and multiply it by 10. So we will get the heart rate. Okay, so this is how we will calculate the heart rate in irregular rhythm. Now, why it is different from heart rate recorded by the automatic machine? Because automatic machine cannot measure irregularity, because atrial fibrillation causes inadequate heart contraction resulting in a small volume pulse. Then what is the cause of AFib in this patient? So in this patient, as the patient has perforated viscus, so in this patient the cause of AFib can be hypokalemia, sepsis or ischemic heart disease. Okay, then how we will manage the atrial fibrillation? So the management, first we will manage the underlying cause. Okay, then there are two treatment options for atrial fibrillation. One is cardioversion and the other is anticoagulation. In the cardioversion, we can do chemical cardioversion or DC shock. So in the chemical cardioversion, we will give amiodarone 30-100 mg in a large vein over 10 to 20 minutes, followed by 900 milligram over 24 hours. Okay, then anticoagulation. In the anticoagulation, we will give an unfractionated heparin 80 units per kg as a bolus, then 18 units per kg per hour till adjusting APTT to 40 to 60 seconds. Okay, dose of low molecular weight heparin is 1 milligram per kg in a BD. Okay, so this is how we will anticoagulates, give the anticoagulants in the atrial fibrillation. Then the differential diagnosis of perforated viscus, it can be ruptured diverticulum, perforated duodenal ulcer, ischemic bowel, necrotizing enterocolitis. Okay, then other causes of abdominal pain in this age group. Okay, so the other causes can be mesenteric ischemia. How to consent in such case? Since the patient is confused, we will proceed for the operation for the patient's best interest with the signature from two consultant on the consent. So it is called consent form 4. Okay, then the next station is of ruptured abdominal aortic aneurysm and hypothermia. So the scenario is 66-year-old woman undergoing laparotomy for ruptured abdominal aneurysm, prolonged surgery and blood loss of about 4 liter, core body temperature was dropped to 35 degrees. See, on entering the station, you are given a chart which will be showing the hypothermia. Now, the first question, define pre-operative hypothermia. So, pre-operative hypothermia under anesthesia, hypothermia is defined as a core temperature less than 36 degrees C, but hypothermia in general is temperature less than 35 degrees C. How to measure core body temperature intraoperatively? So, we can use by esophageal probe. Then the risk factors for the hypothermia is major surgery, exposed surgery, massive blood transfusion, combined general and regional anesthesia, and preoperative temperature less than 36 degrees C. Okay, so these are the risk factors for intraoperative, perioperative hypothermia. Okay, then etiological factors for hypothermia. Okay, etiological factors for perioperative hypothermia, it can be due to heat loss through radiation to cold objects in theater, then increase heat loss through evaporation from the body surfaces and open cavities, then the increase heat loss by direct transfer of heat to operating table and cold infusion fluids. So the perioperative hypothermia can be due to radiation, evaporation and conduction, but major heat loss is through the radiation. Okay, then the other causes can be massive blood transfusion. Okay, heat loss by warming the cool air around the patient, it is convection. Okay, then the blood loss like hypovolemic shock, anesthesia. Okay, so anesthesia can lead to hypothermia by cooling effect of cold anesthetic gas, hypothalamic function altered by anesthetic agents. Okay, decreasing heat production, heat will not be generated, shivering due to skeletal muscle relaxant and abolish behavioral responses. Then the reduced muscle activity and reduced metabolic heat production. These all effects can be caused by anesthetic agent. Okay, and it can lead to hypothermia. Then the next question, mechanism or ways of heat loss. So it can be due to radiation, evaporation, conduction and convection. Radiation is the most common cause of the heat loss. Okay, so 50% of the heat is lost by radiation. Okay, so this diagram shows the radiation 60%. Okay, so the radiation to the other the transfer of heat or temperature to the other cold bodies in the theater. Then the conduction, this is convection. Okay, convection to air, it is 15%. Conduction to objects like the operation table is through conduction, which makes 3%, and then evaporation makes 22%. Evaporation of temperature or heat from the body surfaces or open cavities. Okay, then the question 4, give one potential intraoperative problem that may arise as a result of hypothermia in this patient. So in the hypothermia can lead to coagulopathy. Okay, cardiac arrhythmia and myocardial ischemia. Then the complications of hypothermia, it can be cardiovascular, which include decreased cardiac output. Okay, arrhythmias, vasoconstriction, ECG abnormalities. Okay, increased PR interval and wide KMRS complex. Then it can be respiratory complications like increased pulmonary vascular resistance and ventilation perfusion mismatch, decreased ventilatory drive, increased gas solubility. Then renal complication can be decreased renal blood flow and glomerular filtration rate and cold diuresis. Then hematological complication can be reduced platelet function, coagulation, and increase fibrinolysis, increase hematocrit, left shift of the oxygen dissociation curve. Metabolic complication is are reduced basal metabolic rate, metabolic acidosis, insulin resistance, and hyperglycemia. Gastrointestinal and hepatic complication is reduced gut motility, and the neurological complication is reduced cerebral blood flow, impaired conscious state leading to coma. Okay, so these are complication of hypothermia. Then how to prevent these complications? So we will follow the nice guidelines. Okay, avoid prolonged fasting, do not do induction unless core body temperature is 36 degrees C. Avoid prolonged surgery. Theater temperature should be maintained at 21 degrees C. Wear hugger system, patient warming device, okay, should be used. Warm IV and irrigation fluids are used. Patient exposed only as needed, and post operatively the patient should not leave the recovery room to the ward until core body temperature is 36 degrees C. Okay, so these are the precautions to prevent the hypothermia and its complications. Then types of blankets used in hypothermia. So we can use space blankets, blizzard blankets, wool blankets, heat pockets. Okay, so these are the blanket. This is showing the space blanket, and this is dead bear hugger warming device. Okay, definition of DIC. So DIC is disseminated intravascular coagulation. It is pathological consumptive coagulopathy due to activation of the coagulation and fibrinolytic system. So in this DIC, the coagulation and fibrinolytic system both are activated, which causes the formation of microthrombi in many organs with the consumptions of the clotting factors and platelets. Okay, so it is characterized by widespread hemorrhage, thrombocytopenia due to consumptive coagulopathy, decreased fibrinogen, and increased fibrin degradation products. So this flow chart is showing the pathogenesis of the disseminated intravascular coagulation. So the causative agents for the DIC, it can be massive tissue destruction. Okay, it can be products of conception, it can be sepsis, or it can be any cause which lead to endothelial injury. So these causative agent leads to release of tissue factor. Okay, and release of tissue factor causes the widespread microvascular thrombus. Okay, and this thrombus can occlude the vessel's vascular occlusion, which can lead to microangiopathic hemolytic anemia. Then the vessel occlusion can also lead to ischemic tissue damage. This is one of the effect of microvascular thrombosis. Then microvascular thrombosis can also activate the plasmin. Okay, and plasmin, what plasmin do that it causes the breaking down of the fibrin. Okay, so it causes the fibrinolysis, which cause the fibrin split product to increase. Then the fibrin split products causes the inhibition of thrombin, platelet aggregation, and fibrin polymerization. Okay, so inhibition of thrombin, platelets, and fibrin polymerization can lead to bleeding. Okay, it can lead to bleeding. Then activation of plasmin also causes the proteolysis of the clotting factors. So when there is decreased clotting factor, so also it can lead to bleeding. Okay, then the third effect of the widespread microvascular thrombosis is that the thrombosis, for the formation of microvascular thrombosis, there is consumption of clotting factors and platelets, which can further lead to bleeding. Okay, so this is how DIC works. Also, the endothelial injury also cause platelet aggregation, okay, which can lead to widespread microvascular thrombosis. So this is how the DIC is processed. Okay, then look for the blood results. What can you see? So you will be shown the blood results, which will show the coagulopathy and anemia. Okay, then causes of DIC in this patient. Okay, in this patient it can be severe hemorrhage, okay, massive blood transfusion and hypothermia. So these are the causes in this patient which lead to DIC. Treatment of DIC, we in the immediate management of the DIC is that we should give the fresh frozen plasma, the platelets and cryoprecipitate. What else can assist in correcting this patient's bleeding? So actively warm the patient, because it is the hypothermia that can lead to coagulopathy and DIC. So actively warm the patient by fluid warmer, force hot air like bear hugger system. Then consider agents like tranexamic acid. Then who to involve in care? So we should involve the hematologist to prepare warm blood and anesthesia consultant. Then indications of platelets transfusion. So the platelet is transfused when there is platelet loss or platelets consumption, dysfunction of platelets, okay, any cause of thrombocytopenia less than 50 into 10 raised to power 9 platelets. So if the platelet is less than 50,000, then we should give the platelets. Then in the disseminated intravascular coagulation, we must give the platelets and post cardiopulmonary bypass. Okay, so these are the indications of platelet transfusion. Then the shelf life of the platelets is 5 days. Okay, then the question 14 is stages of homeostasis. So in the homeostasis, first there is vasoconstriction, smooth muscle contraction by local reflexes, thromboxane A2, serotonin release from the activated platelets, which cause the vasoconstriction. Then there is platelet activation and formation of the platelet plug, which is temporary plug. Then the definitive plug is formed by the intrinsic and extrinsic pathway, which is fibrin plug. Okay, so this diagram shows the stages of homeostasis. So first there will be vasoconstriction when there is vessel injury or any injury. Okay, so when there is vessel injury, so first there will be temporary plug by the platelet plug. There will be platelet recruitment and contraction of the platelets, which causes the platelet plug. Then there is activation of clotting system, okay, which can lead to fibrin plug, and the fibrin plug is definitive clot. Okay, how does vascular surgery interfere with each of these three phases? Okay, so if surgeon removes section of vessels, vascular contraction will be impaired. Formation of platelet plug will be impaired by thrombocytopenia and hemodilution, while the fibrin formation will be reduced because of clotting factors will be diluted by massive blood transfusion. Okay, which factors will be deficient in stored blood? So the factor 5 and 8 would be deficient. Then the question 13, measures to reduce blood loss intraoperative. Okay, intraoperative measures to reduce need for transfusion apart from prevention of hypothermia. So measure to reduce blood loss intraoperatively is first the cell salvage, system like which is called autologous transfusion, then hypotensive technique, then the good hemostasis. Okay, what is autologous transfusion? Blood transfusion. So it is recovering blood lost during surgery and re-infusing it to the patient. It is called autologous transfusion. What is massive blood transfusion? So massive blood transfusion is the replacement of more than 50% of the of the patient's blood volume in 4 hours. Okay, so the replacement of 50% of blood in 4 hours. Okay, then the next question, what will be the complications of the massive blood transfusion? So massive blood transfusion can lead to fluid overload, hypothermia, electrolyte disturbances like hyperkalemia, then hypocalcemia due to chelation of calcium by the citrate, ARDS or trolley, transfusion related acute lung injury, thrombocytopenia, coagulopathy, okay, and multi-organ failure. Okay, then early post-operative complication of abdominal aortic aneurysm. Post-operative complication can be organ failure, continued hemorrhage, limb ischemia, MI, stroke, abdominal compartment syndrome, bowel ischemia, and spinal cord ischemia. Okay, so this image is showing the coagulation pathway. So the result of the coagulation pathway is to form the cross-linked fibrin clot. So the cross-linked fibrin clot is made by the fibrin, okay, which is activated factor 1, and it is formed by the fibrinogen, which is unactivated form of factor 1. This fibrinogen is converted to fibrin by the thrombin. Okay, thrombin is factor 2, activated factor 2, while the unactivated factor 2 is called prothrombin. Okay, now how it is prothrombin is converted to thrombin? How it is converted? So it is converted by factor 10A. Factor 10A is the activated form of the factor 10. Okay, so this up to this pathway, when the factor 10 is activated and it converts the prothrombin into thrombin, this pathway is called common pathway. Okay, common pathway. But above this or before this, the events which occur to activate the factor 10 to activated factor 10 is can be divided into intrinsic pathway, okay, which is also called contact activation pathway, or and the second pathway is tissue factor pathway or extrinsic pathway. So the intrinsic pathway start when there is vessel injury or damaged surface. So damaged surface causes the activation of factor 12 to activated factor 12. Then activated factor 12 causes the activation of factor 11 to activated factor 11. This activated factor 11 converts the factor 9 into activated factor 9, and then activated factor 9 in combination with factor 10 activated factor 8, sorry, 10 not 10. So factor 9, activated factor 9 and activated factor 8 converts this factor 10 into activated factor 10, and then the common pathway will be start. Okay, so the intrinsic pathway include the factor 12, then factor 11, okay, then factor 9, and then the common pathway. The factor 9 activate the factor 10, okay, then the factor 10 will activate the factor 2 with the help of factor 5, okay, and then factor 2 will activate the factor 1. So this is common pathway. This is the intrinsic pathway. Now the extrinsic pathway will start from the trauma also, which release the tissue factor, and the tissue factor will convert the factor 7 into activated factor 7, and then the activated factor 7 will convert the factor 10 into activated factor 10. Okay, so the extrinsic pathway will include the factor 7, and this activated factor 7 will convert the factor 10 into activated factor 10, and this is the also the common pathway. Okay, so this pathway is similar for both intrinsic and extrinsic pathway, but the extrinsic pathway will include this factor 7, while the intrinsic pathway will include the factor 12, 11 and 9. Okay, as the factor intrinsic pathway is longer, then it will be checked by the APTT. Okay, while the factors extrinsic pathway is smaller than intrinsic, then it should be measured by the PTINR. Okay, so this is about the coagulation pathways. Then the next station is of pneumothorax and CV line, central venous line insertion. The scenario is iatrogenic pneumothorax following CVP line insertion. Okay, system for reading chest X-ray. So the mnemonic is A, B, C, D and E. First we have to check for the airway, then bone, then cardiac, shadow, diaphragm, equal lung fields, gastric bubble, hilum and mediastinum. But before commenting on these things, okay, we have to confirm, or we have to tell about the age and other demographics of the patient, and the view of the X-ray and the adequacy of the X-ray. Okay, so this is how we will read the X-ray. You will be given a chest X-ray interpret. Okay, so this is chest X-ray. You can see this is the X-ray of the mediastinum. Okay, pneumothorax. You can see the shift in mediastinum. Okay, there is air. Okay, this is air which shift, which compress the mediastinum, which can displace the heart and other vessels, producing the pneumothorax. Okay, so the diagnosis will be simple or tension pneumothorax. Is this adequate chest X-ray? No, because we cannot see the costophrenic angle. So we have to check the adequacy of the chest X-ray. Okay, types of pneumothorax. It can be open versus closed, simple versus tension, and primary versus secondary. Difference between the tension and simple pneumothorax. In tension pneumothorax, the trachea and mediastinum is shifted to the opposite side. There will be tachycardia, hypoxia and hypotension. Emergency situation will require urgent needle thoracostomy in the 4th or 5th intercostal space interior to the mid-axillary line, then the tube thoracostomy in the 5th intercostal space mid-axillary line within 30 minutes. There is continuous entry of air through a one-way valve, but in a simple pneumothorax there will be no cardiovascular compromise. Okay, so this is how the tension pneumothorax is differ from the simple pneumothorax. Then safe triangle of insertion of chest tube. Okay, so we will discuss the boundaries of the safe triangle for the insertion of the chest tube. Interiorly, the safe triangle is bounded by the lateral border of the pectoralis major muscle. So this is interior border formed by the lateral border of pectoralis major. Then the posterior border is formed by the mid axillary line or interior border of latissimus dorsi. Then the inferior border is formed by the line drawn from the nape line backwards. Okay, so this is the line which is drawn from the nape backward. Okay, and the apex is formed by the axilla. Okay, so the boundaries of the shaped triangle is interiorly there is lateral border of pectoralis major, posteriorly the interior border of latissimus dorsi. Apex is formed by the axilla and the base is formed by the line drawn from the nape, okay, backward. So this is the boundaries. Indications of central line insertion. So it can be for monitoring of fluid balance and fluid resuscitation. Central line can also be inserted in TPN, total parenteral nutrition, certain fluids and medication like potassium rich fluids, failed peripheral venous access, hemodialysis, transvenous cardiac pacing. Okay, so this is the indication of central line insertion. Then complications of central line insertion, it can cause infection, thrombosis like DVT and air embolism, arrhythmias, injury to the like the perforation of the right atrium causing the cardiac tamponade, pneumothorax, arterial puncture which can lead to hemorrhage, pseudoaneurysm and hemothorax. Left internal jugular vein cannulation will cause the damage to the thoracic duct which can lead to chylothorax. So these are the complication of central line insertion. Then what will be the nice guidelines for the insertion of the CVP? Okay, central venous line, nice guideline for insertion are: insertion will be under ultrasound guidance, post procedure radiograph for position of the radio opaque tip in the superior vena cava just superior to its entry in right atrium and pneumothorax. Okay, technique for insertion of central venous line. Okay, so first we have to select select the landmark. So the anatomical landmarks are mastoid process, carotid pulse and the depression between the two heads of sternocleidomastoid immediately above the clavicle. So which anatomical landmark we will locate? The clavicle and two heads of sternocleidomastoid. In the center of the triangle formed by the previous landmarks like the mastoid process, okay, above is the mastoid process, then the carotid pulse, the depression between the two heads of the sternocleidomastoid and the clavicle. Palpate the carotid artery and insert the needle lateral to it. Okay, the needle is directed at 30-degree angle towards the patient in the coronal plane, aiming towards the ipsilateral nape. Okay, so first we will have to select the landmarks. The landmarks are mastoid process, okay, then the carotid pulse and the depression between the two heads of sternocleidomastoid and the area above the clavicle. So in the area above the clavicle we will insert the needle just lateral to the carotid pulse in the depression between the two heads of sternocleidomastoid. So this is how we will do the central venous line insertion. Then removal technique For removal technique, there will be the head will be down to prevent the air embolism with compression. Indications of removal. So first indication that there is cessation of cardiac support through inotrope, resolution of the acute problem. There is line sepsis. Okay, so sepsis related to the central venous line, and when the person is discharged. So these are the indication for the removal of central venous line. Then the sites for inserting a central venous line is internal jugular vein, subclavian vein, femoral vein, and peripherally inserted central catheter. Peripherally inserted central catheter, PICC. Landmark for internal jugular vein, it is just lateral to the carotid artery between the two heads of sternocleidomastoid. Insert direction in the direction of ipsilateral nipple. Okay, then organism which causes the infection in the central venous line is staph epidermidis. How to prevent central venous line infection? Perform hand hygiene, apply appropriate skin antiseptic, ensure that the skin preparation agent has completely dried before inserting the central venous line. Then use all 5 maximal sterile barrier precautions: sterile gloves, sterile gown, cap, mask, and large sterile drape. Once the central line is in place, follow recommended central line maintenance practices. Wash the hands with soap and water or an alcohol based hand rub before and after touching the line. Remove a central line as soon as it is no longer needed. The sooner the catheter is removed, the less likely the chance of infection. Okay, so this is how we can prevent the central venous line infection. Then the next station is of pulmonary edema or fluid overload. Okay, so let's discuss its scenario. Post-operative patient, fluid chart plus vital chart inside the station. Patient has taken crystallides plus colloids, about 7 liters, 4 liters of them are normal saline. Now he is tachycardic, hypertensive, and desaturated oligo. Okay, so let's discuss the questions. What are your expected physical findings? So as there is fluid overload, okay, the patient received the 7 liters of colloids and crystallides. So there will be congested neck veins, puffiness of face, lung crepitations, and confusions. The X-ray is given, so interpret this chest X-ray. So first we will have to confirm the age, the gender, and then the view of the X-ray, the adequacy of the X-ray. Then we will comment on the pathology. So there is pulmonary edema, loss of costophrenic angle, and cardiomegaly. Okay, so the chest X-ray findings in pulmonary edema is first A, B, C, D. Okay, A for alveolar edema, which is called bat wing or butterfly edema. So okay, alveolar edema, bat's wing edema. Then B for curly B lines, okay, which shows the interstitial edema. Then the C for cardiomegaly, okay, cardiomegaly, increase heart shadow or cardiac shadow. Then the D for dilated prominent upper lobe vessels, okay, dilated upper lobe vessels. Then the next question is, why is this patient on high risk of MI? So as there is tachycardia, which lead to decreased diastolic time, which decrease the coronary filling, also it increase the cardiac load. So that's why the patient has high risk of MI. There is decreased coronary blood flow due to tachycardia, due to decreased diastolic time. What is minimal urine output? In adults, The minimum acceptable urine output is 0.5 ml per kg per hour. Can you explain why the patient is oliguric? Okay, so as the patient is post-operative patient, okay, so uh, he is oliguric due to stress response to surgery. Okay, so the most common cause is due to physiological stress response to surgery in the first 24 to 36 hours post-operatively. This is due to circulating corticosteroids, glucocorticoids, and mineralocorticoid inducing salt and water retention. Okay, so that's why he is oliguric. Then the second reason is surgical trauma and various anesthetic gases also stimulate the release of vasopressin from the posterior pituitary, stimulating post-operative solute-free water retention. Then the third reason is congestive heart failure with low renal perfusion. Explain what are the fluids given to these patients. Okay, so crystalloids and colloids were given. Amount of sodium in 0.9% saline is 150 millimole per liter, while amount of sodium in Hartmann solution is 131 millimole per liter. How to manage fluid overload? So we can give Lasix, morphine, oxygen nitroprusside, aminophylline, rotating tourniquet, inotropic agent. Daily requirement of sodium and potassium. Sodium is 1 to 2 milli equivalent per kg, while potassium is zero point 0.5 to 1 milli equivalent per kg. What can be done to prevent this from happening? So first they insert a CV line, monitoring the central venous line, monitoring urine output, report to the hospital incident reporting system, better training of junior staff. Management will be through critically care of critically ill surgical patient and ABCDE protocols. Staff all IV fluids, commence high flow oxygen, IV furosemide, glyceryl trinitrate infusion if systolic pressure more than 100. Liaise with ITU registrar. Request chest X-ray, request ABGs and electrolytes, request ECG. Ventilatory support. For ventilatory support, CPAP preferred for cardiogenic pulmonary edema. Okay, non-invasive ventilation. Medical management can be preload reduction through by giving nitrates, GTN like GTN diuretics and IV morphine sulfate. After load reduction can be done by the AC inhibitor like an enalapril 1.2 mg IV or captopril 25 mg sublingual and angiotensin receptor blockers. Inotropic support will be through dobutamine, ideal for cardiogenic shock, or dopamine 5 to 10 mcg per kg per minute for stimulation of beta receptor. So the dopamine has three effects according to the dose. It can be vasoconstrictor, okay, vasodilator, or diuresis, depending upon the dose. Then the next station is, we will discuss the further station in the next lecture.